A new dawn in male fertility management. May I please invite Dr. S.S. Vasan, a visionary in this field, to deliver this thought-provoking oration. Dr. S.S. Vasan is a urology and genitourinary surgery andrologist from Bangalore. Welcome, sir. Over to you. May I please call upon stage the chairpersons, Dr. M. Subhadra Nair, Dr. K. Jayakrishnan, and Dr. Vinod KV. Thank you, sir, for honoring Dr. S.S. Vasan.
Good evening, everyone, and thank you, KGK sir, for this honor and privilege. I'm going to talk about something which is very close to my heart, because when I started andrology, it was only about male infertility, and it was a field where, other than the semen analysis, we had nothing to go forward to. So we are in an era where we are moving from infertility to fertility. What do I mean by that? In the next 30 minutes, I will take you through some of the revolutionary changes which are happening in the field of male infertility. And that's what we are going to discuss. So the challenges have been in male fertility diagnostics for the last 3 decades has been limited diagnostic tools, your genetic testing limitations, hormone evaluation variability, and a lot of invasive and unnecessary procedures, social stigma, and inequitable access. These were the primary challenges in male fertility diagnostics. Compared to female fertility evaluation and growth, there was widespread awareness, holistic approaches, access to testing, integrated care models, and research funding, which was predominantly directed to women and their fertility problems. So these were the challenges we dealt with. And what we have in those era in the last 30 years? Only a WHO semen analysis. Mind you, semen is a multi-parametric evaluation where you assess multiple parameters. It's not a solitary parameter. And consequently, when WHO manuals started reporting semen analysis, everybody got confused, basically because WHO was looking at a contraceptive modality which was effective, and that's why they went into semen analysis reporting, and they wanted to have the minimum value below which fertility was least feasible, and that's what their aim was. Their aim was not to have a fertile range. Their aim was to have the most infertile range, and that's what semen analysis was all about. But we as clinicians confused it to us as a cutoff. That means below this value, there is no fertility chance. Above this value, there is a fertility chance, because that's what we are used to in a Gaussian distribution. So consequently, there was a lot of confusion, some of which has been cleared in the latest 6th manual, which was released about a decade ago, which again has to be revised, where the 5th manual, we had what is called as percentile value, which was the 5th percentile, again below which the theoretical chance of pregnancy was only 5%, and above which people considered everybody to be normal, but it was not the normal group. It meant that your fertility chances were better, but it was not the normal group. So consequently, in the 6th manual, they have abandoned this 5th percentile and moved into decision limits. What is a decision limit? Decision limit is a Gaussian distribution where we follow normal, borderline, and pathological. This is the normal range. You go to any biochemistry test or you have any pathological test, you will have a range. Even in an ultrasound, you will have mild, moderate, severe. Even in a pain score, you will have that. Similarly, in a semen analysis, especially being a multiparametric analysis, we needed a Gaussian distribution, and consequent to this, there's a lot of evolution which has happened in who requires aggressive treatment, who is in the fertile range, whether he requires to be evaluated, whether it needs to be evaluated. All this came into picture only after this Gaussian distribution or the range was created. And what is this borderline range? Now we have moved into an era of 2.5th percentile, because that is the percentile below which the chance of pregnancy is extremely low. So as you can see, there are blue bars which indicate the borderline range. That means theoretically there is a slightly higher chance of pregnancy, but they are not in the fertile range. The fertile range in a concentration is about 36 million, which gives them a 25% chance of a pregnancy. In terms of motility, it's 55%, and similarly in forms of normal forms, it is 14%. So that is the fertile range. So consequently, if you look at this graph, interpretation becomes very, very crucial. That means your semen analysis report cannot be a gibberish report. It has to give you some information for you as a clinician to decide where the fertility of that given individual is. Is he totally infertile? Has he got a 25% chance of fertility? Has he got a 50% chance of fertility? Then you can match it with the female fertility and consequently devise a strategy which is suitable for them in a specific time frame to achieve the pregnancy. So consequently, this is what is the borderline ranges which have been accepted now, because we look at various borderline ranges, because we believe that if you have somewhere around 50% motility, then it is a good enough motility. Beyond that, you are considered to be fertile. Anything between 2.5th to 50th% is a borderline range of motility. That means these are individuals where you could initiate some form of treatment to improve motility, and consequently their fertility chances will improve. So the biggest challenge we have today is the reporting format, because this is what I see most of the labs generating a report in the form of a gibberish information, which does not take away the fact that you need much more information than this. The same information, if it is structured in a different way, you would get a lot of value from this reporting. Again, this is the other format of the reporting which these computerized analyzers have come, and they even thoroughly confuse you, because at the end of the day, what is the information you require? You require an information whether this person's range, is it in the pathological range, is it in a borderline range, or is it in a fertile range, and that's what you require. None of these reports give you this information, and that is the biggest challenge you have. Why do you need that information? Because you have to understand, in a semen sample, there are only two variables. You have the plasma abnormalities, you have the sperm abnormalities, and you need to know specifically whether there is a plasma abnormality. When I say plasma abnormality, it can be the pH, it can be the viscosity, it can be the WBC, it could be the RBC, it could be agglutination, and similarly sperm abnormalities may mean concentration, motility, or morphology defects, and you need to know the degree of abnormality. That is what, as a clinician, you require. That is why you have ordered the test, and the test report should justify that provide that kind of information. So there's a rethinking on how do you generate the report, because the crucial element is generating a report. If you get an ultrasound report tomorrow saying that hypoechoic field seen, hyperechoic field seen, mixed echogenicity, you will be thoroughly confused. You want to know whether it's a cyst, whether it is a solid tumor. You want a clear picture. Similarly, if your CT scan gives you a Hounsfield unit, you would be thoroughly confused. So similarly, in a semen analysis, we have now standardized. There are working on standardizing the report format, and this is one of the format of report where in the top bar you will see all the plasma abnormalities, and then you will see the sperm abnormalities, and it will also give you where does this sperm abnormality lie in terms of the percentile chance for him. And finally, the reporting will conclude by saying sperm concentration is normal, motility is borderline, morphology is borderline. So you get a clear picture as to where you need to intervene, or what is the fertility status of that given individual is, and consequent to that you can plan out your strategy in terms of what you want to do, whether you want to do an additional testing, physical examination, corroborative history, whatever you want to do, it can be easily decided on the basis of the semen analysis. So similarly, a borderline report, there are various forms of reporting, but generally the main theme of the reporting is segregation of plasma abnormalities and sperm abnormalities, and giving a conclusion to the report, not oligoasthenoteratospermia, because oligoasthenoteratospermia is not a conclusion. Oligo means anything between 0.1 to 15 million. Astheno means the same way. it's a range, and consequently the range has to be interpreted as whether it is a normal range, whether it's a borderline range or a pathological range, and then only you can move forward in terms of your diagnosis. And similarly, if a clinician gets a report saying low volume pus cells present in the semen sample, then you know immediately what would be your management strategy in terms of it. Fertility is all about understanding, firstly, where does the semen analysis lie, whether there's a need for intervention in the form of diagnostics, whether I can straight away manage this patient, and then seeing how you want to proceed with the next step in terms of improving fertility of that given individual. So the various, why am I stressing on this? Because fundamentally, unless we change the way semen analysis is reported across the labs, unless we clinicians insist that you want a report in this format, most of the labs will adopt it. The way I visualize it, most important to understand that we need to change the way the reporting is done. If the reporting is done in a user-friendly format which the clinician understands, then for him to plan a management becomes very, very crucial. So that is what is the highlight. So the path to infertility to fertility is simple change in the way you report a semen analysis. Then as a clinician, if the report is presented to you in a decent format, then you can QC the report in terms of whether there was a sufficient period of abstinence, whether there was spillage, whether there was any other modalities used in terms of contamination of the sample, and then you look for volume abnormality, pus abnormality, bacteria, RBC. These are the plasma abnormalities, and fructose is only necessary in a case of azoospermia, and consequently you will be able to manage, because that is the first step in terms of management. And if the seminal plasma shows no abnormality, then you focus on the sperm abnormality. That is the management strategy of any male infertility patient. Don't worry about the oligoasthenoteratospermia reading which is given to you at the end of the report. You go by whether there is a plasma abnormality or a sperm abnormality. If there is a sperm abnormality, then you need to decide which of the sperm parameters are abnormal. Is it a concentration defect? Generally, motility and morphology are the only two defects that matter, because concentration always goes hand in hand with motility and morphology. And then you decide where the range lie. Is it a pathological abnormality? Is it a borderline abnormality? Is it a normal sperm parameter? And then decide on the severity of the female factor, because male factor alone doesn't decide the prognosis of a fertility in a given patient. Decide on the modality of treatment based on the woman's age, based on her AMH value, based on whatever other parameters you consider are critical for a pregnancy from the point of view of female. Then you decide on the male factor treatment in terms of or further evaluation of the male. So consequently, these are the various steps which are involved. Once a proper report is presented to you, it becomes very easy for you to position yourself as a clinician, and you understand the report, and then you can proceed to the next step. Now the second question is, in the path to fertility, is semen analysis enough for fertility understanding? Is sperm functional test necessary at all? Is it time for its routine use? These are some of the questions which we always ask. Now I always compare infertility to fertility. If you want to make a diagnosis of fertility, you have a chest pain, you go to the emergency room, they do an ECG, and your chest pain persists, they're not going to leave you there. They obviously have to do an echo and a stress test to further evaluate. Similarly, in male infertility, a semen analysis is just a screening test. It's just a screening test to indicate to you whether there is a significant problem or there is no problem. If there is a significant problem, depending on what modality, where the problem lies, then you decide whether there is a need for the sperm functional test. There's been a gamut of tests which have evolved in the sperm functional testing. I'm not going to go into details of this, but most of them have fallen by the wayside because they were not specific, they were not routinely possible to do, and they were cumbersome to do. So what has evolved over the period of time is that we want to understand whether the sperm is capable of fertilization, whether it is capable of penetrating the ulama. That is what you require in terms of it, and whether the embryo is going to be normal or it's going to be a dysgenetic embryo. That's what you want to understand. So what are the tests which are evolving? The tests which have evolved, which are almost routinely used nowadays, is the DNA fragmentation test, then your reactive oxygen species, then your acrosin proteolytic activity or izumo-1 protein, which is evolving, and then you have annexin V binding, which is again an evolving test, where there's a lot of information which is going to be given to you on a platter on the basis of functional characteristics of the tech. Semen analysis is a morphokinetic analysis which gives you only the morphology or the external appearance of the sperm, but when you look at the internal characteristics of the sperm, you need much more information. So DNA fragmentation, I'm sure there are many lectures which you have gone through, and I'm not going to go into that, but it is a critical component of the sperm internal characteristics to produce a viable embryo which is genetically normal, and also probably to reduce the risk of pregnancy. There are specific guidelines in where you have to do this test to give you the information. Now, what are the types of DNA damage? There could be a replication error, and it could be induced by ROS, it could be induced by ROS, UV light, alkylating agents, induced by carcinogenic agents, and ROS induced by UV light. So there are all sorts of things which can cause a DNA damage in terms of mismatch bases, abasic sites, base modifications. You can have various types of, though the DNA is adenine and thymine, cytosine and guanine, but you can have single strand break, double strand break, which lead to that. And we've heard enough about reactive oxygen species where there's an oxidative excess in the cytoplasm, which can lead to further damage of the DNA in terms of telomere attrition and mitochondrial DNA damage, and finally leading to DNA fragmentation, which can affect fertilization, your embryo development and implantation. And this has been proven by several studies, and there are now routinely these are incorporated in many centers going across, where you want this to be done for all your patients who are going through expensive procedures, because you don't want the procedure to fail because of some element of error in the sperm's fertilizing ability. Now, what are the new tests and what are they all about? So similarly, ROS is the low levels of oxidative stress, which is necessary because low levels can induce hyperactivation, sperm capacitation, acrosome reaction, sperm egg binding, sperm egg fusion, and fertilization. Now, these are the two tests which I find very interesting, which is evolving, which will give you a predictor of fertility. What is acrosin proteolytic? Acrosin is a protein all of you are aware of, which is present in the head of the sperm, which is measured and quantifiable nowadays. And there is also a protein which is found to be izumo-1 protein, which is much more specific, and a deficiency of that can lead to infertility or penetration defects of the sperm. The sperm may look normal morphologically, but it may have penetration defect, and there is a significant correlation to the percentage of acrosome reacted spermatozoa in vitro with fertilization rate, and that's what we are looking at. Now, most important thing is, one is to have a test, second is to interpret it and get you a clinical value or a representable report. So now we are evolving into acrosin proteolytic activity, where a acrosin level of between 1 to 15% is considered to be a pathological option, where you can directly tell a patient that ICSI is the best option, and indeterminate, where 16 to 25 is a low chance of even an IUI success, and a fertile range is about 26%. So this gives you a predictability, it gives you the power of convincing the patient that you have done an advanced testing on the basis of, though his sperm morphologically may be normal, but his acrosin being deficient in a significant way, it would lead to a failure, and if you don't go through the proper attempt. So the fertility is about defining the real path and telling the patient right in the beginning itself that this is the only road for your fertility. Similarly, annexin V binding, this is a very interesting test where the annexin V binding assay is highly sensitive for detecting early deterioration of sperm membrane functions, and in turn the sperm fertilizing ability. So what is this test all about? It can tell you that the phosphatidylysine membrane of the sperm is damaged internally, and that is something which you can only see under the microscope. And then again, in a patient who has 1 to 15%, you can go ahead with an ICSI, but if the annexin test is abnormal or in a borderline range, there are chances of ICSI failure despite the sperm being normal. Because ultimately we have to realize we are still in an era of maximum 40 to 45% or 50% pregnancy rate across various groups or age groups in an IVF cycle, and upping the bar there is very necessary, and we are trying to maximize the best sperm so that we can get the fertilization rates and the embryo the rates into a much healthier level. And especially the most important characteristic is that if the pathological range is there in terms of annexin V binding, where you see reports about 26% and above, then maybe you will have to use a higher magnification to select the sperm, because the sperm which looks normal under 400x microscopy may be abnormal and may lead to a chance fertilization failure. Sometimes it's always mind-boggling. I had selected the best sperm, the oocyte quality was good, but fertilization rates, or the embryo quality was good, but fertilization doesn't happen, or the pregnancy doesn't happen. And this is what bothers the clinician, because how do you explain it to the patient? Because during the process of the IVF cycle, you would have explained you have good sperm, the embryologist will come and explain your oocyte quality was good, we have got 10 oocytes, but at the end of the day fertilization was also good, but you have an implantation failure. One is to blame the endometrium and the female factor. Could it be a sperm factor? That's what we are looking at to optimize the sperm factor. So the male fertility diagnostics is advancing rapidly. Advanced andrology diagnostic predicts the fertility path, especially in cases, though we may not be a country for its routine use, many other countries are following routine use because their insurance covered. Here we have the challenge of the excessive costs which are burden to the patient. So we are looking at specific groups where this may be routinely used in terms of unexplained infertility, recurrent pregnancy loss, recurrent ART failure, severe astheno and teratospermia, and understanding fertility potential of the individual. If a person comes to me a late marriage and he wants to try IUI, I would do this test right in the beginning and tell him, look, your chances of IUI is very low, you might as well go for ICSI, because this test would give me the power of predictability, and it would help you evolve personalized management strategies, selecting the sperm with least DNA defects and other abnormality, because these epigenetic abnormalities are crucial to avoid translation into defects in the future, as well as in terms of embryo loss which can happen. Now, why are these important? One, if a deficiency is found, management pathways are evolving. One is to find the deficiency, second is to identify management pathway, because it's important to identify what deficiency is there, because then only a management pathway can develop. And there are various management pathways, which is not the brief of this lecture, but these are constantly evolving. Now, the other management, I'm still sticking to the term OAT, though I don't like it, but we don't have an alternative term at this point in time. Oligoasthenospermia management is moving into a different era now. That means the medical management strategy evolves into a different era. Why am I saying this? Because physiology of spermatogenesis now we understand very clearly. Radioisotope has been used, and we know that spermatogenesis is a 50-day event and spermiogenesis is a 14-day event, and totally it's a 64-day event in terms of spermatogenic cycle in a given individual. Now, there have been several groups which have been working, because as you can see, just like in AMH, you have an AMH range in women. I'm sure in your laboratory test you get an AMH range of 1 to 10 or whatever it is, but you know at the end of the day, if AMH is dropping below 1.5, it's a poor ovarian reserve, and if it is going above 4.5, you know that there is a chance of hyperstimulation in that given individual. Similarly, we have an FSH range 1.4 to 11. Does it mean that that is a normal range? Because people consider that as a normal range. What is your FSH 1.4 to 11? Oh, your FSH is normal. Your LH 1.4 to 7.8.4, that is the laboratory value of the kit, and on the basis of that you decide that the LH level is normal. So several groups worked on this, and this is a rather busy slide which I don't want to explain. I will explain it in a simple way. There are 5 groups theoretically or practically to tell you. You have to be an endocrinologist to understand this, but generally to say there is a hypo group which is acquired or congenital, which I am sure most of you understand. There is a group of reduced gonadotropin action and functional hypogonadism, which is the second group, and the third group is reduced gonadotropin action and biochemical hypogonadism, which is the third group, and the fourth group is functional hypogonadism, and fifth group is unexplained male infertility in the context of unexplained couple infertility. So these are various groups. groups, but how do I decipher this into a proper medical management strategy? Now, this is where my concept of endocrine stimulation comes up, because what you want to improve, or what technically gives you a conception, is only the motility and the morphology. Sperm numbers always go hand in hand with motility and morphology. So you want to improve the Sertoli cell function or the Leydig cell function. These are the two primary cells inside the testis, and your only axis is the HPG axis. Sometimes these cells, why do you have to improve? Because they may be unresponsive, they may have a damage, they may have a blockade, they may be polymorphic, they may be apoptosis, or there may be cell dysfunction. All these are possibilities in kind of it. So similar to AMH range, we believe now that there is a cutoff even in FSH. Now there is a cutoff that anything above F7.6 is abnormal in terms of FSH. FSH value is high, it falls into non-obstructive azoospermia. So that is the range of FSH. But the kit will tell you 1.5 to 11. So we have a challenge in explaining to the patient. Sometimes the patient will say, doctor, you are saying my FSH is abnormal, but the range in the laboratory report, it says that the value is normal, because the value will be reported as normal. So, but we do know that most men do not require FSH of more than 4 for their normal spermatogenesis, and similarly, so these are the ranges which we believe, just like your AMH range, where you have a poor ovarian reserve and a ovarian reserve which is probably polycystic in nature. And similarly, we have this range of less than 4 and more than 7.6 for FSH, and less than 4 and more than 8 for LH. And so this becomes very simple if you create that range. Then the treatment option to stimulate the HPG axis, especially if you have identified hypogonadal or eugonadal values, irrespective whether it is hypogonadal or eugonadal, because most men will have eugonadal values, they may not be hypogonadal, and you want to artificially increase their intratesticular testosterone to see whether there will be a better output. So if there is a low normal FSH alone, you give him clomiphene. If there is a low normal LH alone, you give him clomiphene or HCG. If there is a high normal FSH and LH, then you either try recombinant therapy, preferably recombinant. If you can't afford, you can go for urinary therapy. So the dosages which are normally recommended, especially if you are using recombinant, is 150 international units subcutaneously every other day. For patients under 70 kgs, consider starting with 75 IU subcutaneously every other day. Similarly, for HCG, 2000 international unit, these are stimulations specifically directed at a particular cell which you believe is dysfunctional or dysgenetic, and you want to stimulate that axis alone. And that is the concept of this. And aromatase inhibitors, if estradiol level is very high, and also adding linarol or estradiol 1 milligram in case estradiol it seems to be less than 30, we add linarol because it is necessary for sperm dysfunction or sperm improvement. That is in cases of oligoasthenoteratospermia, or where you find motility and morphology in the borderline and pathological. What about azoospermia? Where are we in the terms of azoospermia? Because is it necessary to manipulate the endocrine axis in an azoospermic patient, especially if it is non-obstructive azoospermia? Because we know that despite varied etiology, there is a chance of multifocal isolated spermatogenesis in those, and in those not present, they still have spermatids. Many a times I am faced with this situation where we do the best of the micro-TSA or whatever extraction you want to do, and you get spermatids, and the patient will ask you, is there any chance of them being normal in due course of time? What is your answer? So there have been several attempts at trying to see whether we can change the spermatids into spermatocytes in those individuals, and whether the only option in these individuals are in terms of manipulating their endocrine axis. Now, if you want to understand non-obstructive azoospermia, there are broadly two groups of non-obstructive azoospermia. One is what is called as a eugonadal non-obstructive azoospermia. The other is the hypogonadotropic hypogonadal or normogonadotropic hypogonadal. These are the two types, which is NOA type 1 and NOA type 2. That means in one, the testosterone level is normal, but still the peripheral testosterone, we only measure the peripheral testosterone, you don't measure the intratesticular testosterone, but still there is a sperm abnormality, or there is a classical hypogonadal state less than 300 nanogram per DL in terms of testosterone, and there is a sperm abnormality. The one which is hypogonadal is very clear, and you know what to do, because there is an associated biochemical defect and you want to correct it. The challenge is in eugonadal, which will present in about 63% of cases. Eugonadal is the state where you will see where there is a non-obstructive azoospermia, peripheral testosterone is more than 300, and you would probably end up in these kind of patients maturation arrest or which is the most common, whereas if you have hypogonadal you end up with Sertoli cell only syndrome or hypospermatogenesis, and there is an indication in those cases to treat this individual. So again, if you look at the two eugonadal which means that the testosterone, peripheral testosterone is more than 300, again has two subtypes based on the FSH and LH levels. If the FSH level is less than 7.6, which is normal, LH is less than 8, which is again considered normal, or you have the high group where the FSH is more than 7.6 and LH is more than 8. So this is, one is normogonadotropic eugonadal azoospermia, hypergonadotropic eugonadal azoospermia. So these are the broad definition of azoospermia. You need to classify them on that basis, then your management becomes very simple. If your endocrine testing has come to age now, we now know that NOA is two types, and eugonadal NOA where testosterone is more than 300, which is considered normal peripheral testosterone. Do you still require to stimulate them? Is there any benefit of stimulating these men? Will it improve your chances of sperm retrieval? That's what you are asking. Now we know that especially in these cases, there is no harm in stimulating these men because your chance of tubular movement of the cell of the sperm from the tissue, from the Sertoli cell or from the basement membrane towards the tubule or towards the rete testis happens by higher intratesticular testosterone, and that is what you want to see. You want to see more movement of the sperm into the tubules, and consequently your sperm retrieval chances will improve. It may not convert a patient of azoospermia to an ejaculate sperm, but it will make the process of finding the sperm much easier. So what is the cutoff you want to achieve? He is already eugonadal, he has already got 300 nanogram per ml. The total testosterone cutoff we want to achieve in these individuals is 400 to 600 nanogram per ml, and depending on the axis, whichever axis you feel is abnormal. I presented that FSH, if it is low you stimulate FSH axis, LH if it is low you stimulate LH axis, and estradiol again you add if it is less than 35, and of course inhibin is a broad marker of sperm function. So you stimulate that axis. Now how do you know that you have stimulated the axis and you get the end result? If the FSH level after 4 weeks of stimulation moves by 20% and there is no corresponding increase in the testosterone level, then there is a definite cell dysfunction, and in those individuals HPG axis stimulation will not work. If the movement happens, that means FSH level or LH level has to move by 20% by your stimulation by 4 weeks of stimulation, and that is the guideline which you have to remember, and that gives you an idea that within 4 weeks you can reassess the endocrine values, and if you expect some amount of response, because this is important. How long do you stimulate? When do you intervene? The patient has come to me, I am going to give him endocrine stimulation. When do I call him back for a procedure? Usually 4 weeks is good enough. At the end of 4 weeks, if the testosterone has improved to 400 to 600 nanogram, or if the FSH level has doubled and he is not improved, then he is not going to improve further. So that's the way it is. So the one is we have covered now the basic diagnosis, the advanced diagnostics, your OAT management, azoospermia management. All of them are directed at improving the fertility chances, not the infertility, fertility chances. Next comes the sperm morphokinetics, identifying the best sperm for to maximize fertilization. You had the laser assisted sperm selection, but that fell out of the way. Now we are looking at birefringence based sperm selection, fluorescence activated sperm selection. These are very useful techniques. This is an evolving field. There's a constant evolution. We also had the Pixie dish, Gaber-Huzar's dish, and then you had the IMSI and various protocols which have come in. But this is a challenging field where identifying the best sperm, not on the basis of only morphokinetics, but looking at the head and trying to find out vacuoles in the head and identifying whether the sperm is genetically normal in terms of its DNA content, and that is the challenge in these sperms. So there is a lot of work in progress in terms of infertility to fertility journey. Genetic insights, increased access to genetic testing helps identify specific mutation and chromosomal abnormalities, enabling targeted interventions and counseling. AI infertility, AI technologies are being leveraged to analyze large data sets from fertility assessments, improving diagnostic accuracy and treatment personalization. There are a lot of work going on in AI, and in the next 5 years, you will see a revolution in the field of infertility. Lifestyle modification, awareness of the impact of lifestyle factors, which I am constantly asked this question: which food should I eat? What should I do? What diet should I follow? What exercise routine should I follow? Now we are at a loss as doctors as to find what is it that we are going to advise these people. But with AI, we are trying to find out what will help. Now there is a general consensus that for male infertility management, best to keep the BMI below 25. If your BMI is below 25, and if you are not elderly, above the age of 40, your chances of sperm improvement are very, very good. So the BMI cutoff has decreased from 28. Earlier we were talking of 30, then we came to 28. Now we are looking at a BMI of 25. And that is the change which is happening. So whatever brings about that change in terms of lifestyle modification is being followed. Personalized medicine. There is no one fit all in fertility management. Fertility treatments are increasingly tailored based on individual health profiles and specific infertility causes, and consequently, each couple is different. Each dynamic situation is different. So there is a need to personalize the management strategy. You cannot have a cookie cutter approach. I'll cut and paste this treatment from that individual to this individual. It doesn't work. And most importantly, psychological support. Integrated care models now often include mental health support, recognizing emotional impact of infertility, which is very necessary. Now, there are certain experimental fields, which is your testicular rejuvenation, which is your HYPE or HOPE. I still don't have answers, but broadly, I've put it down as people are looking at spermatogonial stem cell, epithelial stem cells, and iPSCs, which are generally the stem cells, and the work is going on mesenchymal stem cell, dental stem cell or decidual stem cells, mesenchymal derived exosome. These are all work in progress. Nothing is definitive about these therapies. There's a lot of paper. We also see in conferences people presenting PRP, we have done this, we have done that, we have got sperm. I don't believe anybody has seen any drastic change in the testicular spermatogenic cycle in any of these technologies, but they have shown some promise in animal models, but it is not translated into humans, but I just mentioned this here. So to conclude, good evening everyone. Today we stand at crossroads in reproductive health, a movement where echoes of silence around male infertility can no longer be ignored. Historically, while female fertility has received spotlight, male infertility has remained cloaked in darkness. But it's a call to action. Men too need answers. As we explore the hidden complexities of male infertility, we uncover a powerful truth: untapped potential for innovative diagnostics and life-changing treatments. For years, the focus has been on oocyte, but now with the sperm readily available for research, we have a remarkable opportunity to illuminate the male factor that contributes to infertility. In the decades ahead, we must urgently elevate our efforts to improve male reproductive health. This is not just scientific endeavor, it's a moral imperative. The stakes are high. Considering the staggering decline in global fertility rates, we owe it to those facing azoospermia and other challenges to spark hope and drive advancement. Let us challenge the status quo and forge a future where male infertility is embraced, understood, and treated with the same vigor dedicated to female health. Together, we can dismantle the stigma, provide answers, and open new pathways to parenthood. Thank you very much.
Thank you, Doctor, for the impactful oration and shedding light on the area that truly broadens the approach to male fertility care. May I please request Dr. Vinod KV to kindly present a memento to Dr. S.S. Vasavan as a token of our love. Thank you, Doctor.